Okay, hello and welcome to the OTIS Mother to Baby webinar series. This presentation is provided to you by the Organization of Teratology Information Specialists, or OTIS, and Mother to Baby. My name is Sura Alwan. I am actually not Sheena. I'm not trying to impersonate her in any way, but I am. I've been told that it's best to keep it because she usually holds this account, so I'm using her account. So I am co-chair of the Otis Education Committee along with Lauren Kozlowski, and this presentation today is provided again by the Organization of Teratology Information Specialists Mother to Baby Education Committee. If you wish to become a member of Otis, please visit mothertobaby.org Otis membership. Today is all about uncovering pain management in pregnancy and delivery. This presentation will provide us some information and discussion about pain management during pregnancy and delivery, and is brought to you by our great speakers today, Dr. Sarah Obican and Dr. Anthony Kendle. And before I get started and introduce our speakers more, I'm going to just go through some housekeeping items to ensure you can, interact with myself and the speakers. I'm going to have to ask you to please keep yourself muted throughout this presentation until we reach the discussion part. First, and if you'd like to ask presenters a question, we have an open chat feature enabled, so you can post your comments or questions, and we can get to those at the end of the talks. Just a brief introduction to our speakers today. Dr. Sarah Obican is a board-certified physician in obstetrics and gynecology and maternal fetal medicine at the University of South Florida. She is an associate professor in the Division of Maternal Fetal Medicine, Department of Obstetrics and Gynecology at USF, and currently serves as a division director of maternal fetal medicine and the medical director of fetal therapy at USF. Dr. Obichan's expertise includes caring for high-risk pregnancies with specific interest in birth defects, fetal echocardiography, ultrasound, and fetal therapy. She's the founder of a teratogen information service for the state of Florida, also known as Mother to Baby Florida, and serves as its medical director. She is also currently the president of the Organization of Teratology Information Specialists and the board of Reproductive Toxicology Center, and actively serves in the Society of Birth Defects Research and Prevention. Dr. Obichan is also an associate editor for Birth Defects Research Journal and speaks both nationally and internationally on birth defects and exposure medicine. Dr. Anthony Kendle is a board-certified obstetrician and gynecologist. He is currently completing his final year of fellowship training in maternal fetal medicine at the University of South Florida. One of his clinical focuses includes providing counseling, support, and care coordination for pregnant persons affected by substance use disorders. In addition to substance exposure in pregnancy, his research interests include epidemiology, maternal morbidity and mortality, and healthcare disparities. We are so glad you could make it here today to share your insights on pain management in pregnancy and delivery. And I guess we should just get straight into the content. Thank you.
That's great. Thank you so much. And good morning or good afternoon. It's about noon here on Eastern Time. I hope everybody's doing well. Thank you so much for joining us today. We're going to cover some pain management in pregnancy and delivery. The first thing we're going to talk about the concept of pain. And it's one of those things where it's a most basic of human experiences, right? It is so important in how we experience the world, and it's really prevalent in chronic conditions. Now, we understand that poorly managed pain is a risk factor for things like maternal stress and depression, sleep deprivation and hypertension, and therefore it does have an increased risk in terms of pregnancy outcomes for both mom and that fetus. So we experience physical and psychological pain during the course of pregnancy. And I love this concept, which I don't even think I've thought about it in this way, that pain relief is really a basic human right. It makes complete sense, and it should not be ignored during the time of pregnancy. And what we're here to talk about is not only pain, but really the treatment of pain, which often is through the use of analgesics, a medication class that's frequently utilized for pain management. And its use is really prevalent and is prevalent in pregnancy and anywhere from 11 to 70% in some of the studies, but that depends on the type of patient population you're caring for. We suspect that the utilization of these analgesics will increase. Why? Because we're having a population that is older and that is suffering from more chronic conditions. So we recognize, both Tony and I, that there's a variety of ways to treat and heal pain. That includes things like acupuncture, sometimes local anesthetics for things like cuts, just locally, antidepressants, anti-epileptic drugs, and even cognitive behavioral therapy can be exceptionally helpful. But for the purposes of this talk, because as you would imagine, for any one of these things could take up more than an hour's worth of time, we wanted to kind of hone in our talk to things that are utilized very commonly or that people would most commonly have questions for. So we're going to talk about the role and the uses and the risks of things like NSAID use during pregnancy. We're going to talk about the use of acetaminophen, kind of a hot topic these days, and then the use of aspirin in pregnancy. We'll cover a little bit about labor pain management, and then what's really, I think, interesting and important is the use of opioids and the neonatal abstinence syndrome. So to start with nonsteroidal anti-inflammatory drugs, this is a class of medications that's anti-inflammatory in action, mediated by the inhibition of prostaglandin synthesis. So to first talk about some of the risks associated with this, you would think about maybe miscarriage risks. And this is an old table. I have a reference for it. I just realized I didn't put the reference on the slide, but I had the reference to give you, and there's probably data right after this as well, discussing the risk of miscarriage. It's a little bit all over the place, but one of the biggest studies by Daniel et al., about 65,000 women, the overall risk for NSAIDs was not there. There was not an association, except with the association for indomethacin. I think this one's interesting because sometimes we do tend to use indomethacin in the pregnancy, especially later on in pregnancy. But again, the data on this is mixed, maybe slightly higher for the use of NSAIDs at the time of conception and for a prolonged period of use. Now, I and you probably would argue, well, what are we using the NSAIDs for, right? Are we using it for some underlying condition that would increase that risk of miscarriage? And so we have to be careful when we interpret data like this. In terms of birth defects research for NSAIDs, this is even more kind of helpful, I would say, in decreasing that risk. We don't think there's a risk for birth defects in the use of NSAIDs, with the exception of something I'll talk about in the third trimester, which I think is fascinating. So how do we even use NSAIDs in pregnancy? Most OB says, hey, don't use nonsteroidal anti-inflammatories during pregnancies, but we still do them sometimes. And of course, that's that risk-benefit ratio of deciding who really needs one. So I'll give you an example of what we treat commonly in obstetrics, which are fibroids. So fibroids are not an entity of pregnancy. They actually occur prior to pregnancy, but they are hormonally mediated and they change during pregnancy. A lot of the fibroids will grow. The size, they're benign, but they're going to grow in size, and they can be uncomfortable just due to their size and impinging on different organs of your body. Now, the more important part is these fibroids grow very fast during pregnancy, and they can overgrow their blood supply. They usually have one or two vessels that are supplying that mass, but when they overgrow it too quickly, then it becomes necrotic and it becomes quite painful. It's such severe pain. It looks like an emergency when the patient presents. They come to the hospital, you're ruling out anything else, preterm birth and any kind of appendicitis and so forth. And then you realize, oh gosh, this is really tender over one area of the fibroid. This is probably the cause. And then you can treat it. Now, the way you treat it is an NSAID. And I've never used NSAIDs in pregnancy for an extended period of time, but it's very effective in situations like this. And it breaks that pain cycle effectively, where you can give that for a period of 12 to 48 hours even of high dose ibuprofen or Toradol, and it decreases that pain, and the patient tends to go home like the few days after that. Now, in the third trimester, what are some of the potential causes of problems in the third trimester as well? Initially, really, probably decades ago, we know that in animal studies, NSAIDs decrease uterine activity. And so that was very interesting to the OB providers because, my gosh, can we use this as a tocolytic? Can we effectively stop preterm birth? It turns out that NSAIDs are not a great tocolytic, meaning they're not so effective in decreasing the risk of preterm delivery, but it's still utilized in certain scenarios where if I am concerned about somebody delivering early, in order to allow there to be steroid administration for baby's lung maturity, I may give a short dose of indocin, for example, as an NSAID in the hopes that it would at least stall that labor until the steroids were on board, meaning that that baby had some sort of effect for the fetal lung maturity. What we're really concerned about, and this is a real concern in terms of NSAID use in the third trimester, is that premature closure of the ductus arteriosus. And I'll talk about that in a second. And then additionally, what I'm nervous about is a long-term use of NSAIDs and the risk of having low amniotic fluid. So to explain a little bit of what the ductus arteriosus is, this is a fetal vessel that's important in fetal life because what it does, it allows oxygenated blood that comes from the placenta into that fetus to bypass the lungs in utero. In fact, less than 10% of the blood flow from the placenta ends up going into the lungs. Why? Because lungs are actually very gentle and you can damage them by this high flow into those vessels. And it's not really supposed to, you're not doing oxygenation at that time. What you're doing is developing the lungs to be able to do that process when the baby is born. So it bypasses the vessel going between the pulmonary artery, bypassing the lungs, and it goes into the aorta. And what happens at birth is that the lungs, by default, fill with air and with the first breaths, and then the pulmonary vascular resistance drops, and then the blood flow from the right ventricle actually goes into the lungs where it's supposed to go in order to be able to do the process of oxygenation. Well, this increased arterial oxygen tension and the decrease of blood flow actually through that small vessels, which I showed what it looks like, the ductus arteriosus, it constricts it functionally within a very few hours, and then it closes it permanently anatomically within a couple of weeks. So this is actually, I'm not sure, I should have asked this question. I'm not sure if, oopsies, let me do that. Forgive me for that. I wanted to show you, I'm not sure if you can see my pointer, but this is the aorta here on the top, and you can actually see the vessel between the pulmonary artery and the descending aorta. So what happens normally is that it closes. There is no connection that's supposed to be there between the pulmonary artery and the aorta. In fact, it's a problem if it stays open through neonatal life and then later adult life, because then it can cause damage to those lungs, so they can cause pulmonary edema and a hemorrhage. It can cause actually future pulmonary hypertension. So all the kind of problems in the neonate, and if it's long-term chronic, it causes pulmonary hypertension, which of course is very hard to live with as an adult. So normally what it does, it closes on its own. It's a natural physiology of humans. It closes on its own within that 12 to 24 hours physiologically, in about 2 to 3 weeks physically, and you can help to manage that. So you can help meaning NICU doctors who are really good at the neonatology unit, they can conservatively manage this small patients and then allow increased ventilation to just functionally close that space. If that doesn't work, you actually close it by the use of NSAIDs. So ibuprofen or indomethacin have been classically used to close that ductus arteriosus. And in the newer literature, actually acetaminophen, so Tylenol has been utilized to close that space. And in fact, there's some promise with acetaminophen literature to be able to close that after the baby is born. So that's actually the concern. It's the concern in fetal life that you would close that space too early and that you could have problems related to that. And we've certainly seen that in our practice. Acetaminophen can do that as well. Not in everybody, not as much we don't see clinically as NSAIDs do or can, but it is something we would monitor with things like fetal echocardiography. Now, in 2020, this came out, the FDA recommended avoiding NSAIDs in pregnancy after 20 weeks or later because it can result in low amniotic fluid. Now, that's nothing new. We've known about this for a long time, but the recommendation prior to 2020 was really to avoid it after 30 weeks because that's when the effect is most found. We just noted that in some babies, it can happen earlier. It's mostly attributed to the fact that you have chronic use of NSAIDs, right? And so we really should be utilizing something else if possible for patients who are pregnant so that we don't have this issue of low amniotic fluid. So acetaminophen. And overall, if you ask obstetricians, they would say, look, it has the best safety profile in terms of pregnancy when utilized appropriately for the appropriate indications. We don't find an increased risk of congenital malformations or increased risk of miscarriage or stillbirth outside of what we'd be concerned about, just like with any other data from the underlying conditions that we're actually treating. So a Danish population-based cohort looked at the risk of preterm birth in women with the use of acetaminophen, and they found an increased hazard ratio, for those women who had preeclampsia. Well, when you piece out those patients who had preterm birth and preeclampsia and those patients who had preterm birth and without preeclampsia, it's the preeclampsia that was the signifying factor that increased that risk. As you may know, and somebody who has preeclampsia, the way we treat preeclampsia, even to this day, is actually delivery. If we have a really sick patient, in order to be able to save her life and to decrease the morbidity for the mom, we have to deliver her to stop the physiology of preeclampsia. Now, there's some also data that comes out with NSAIDs too, but with prenatal paracetamol exposure, that there might be an increased risk of asthma in the child. So later on, at 3 years of age, and with NSAIDs about 7 years of age, depending on the study that you're looking at and what their outcomes was looking at, there might be an association there. In the end, just like anything else, we're supposed to be using acetaminophen when necessary for certain treatments because we don't have anything else, and we need to be able to treat pain and fever, for example. But this actually comes from a friend. I was lucky enough to go to the OTIS meeting this year, and Dr. Yusuf Kaplan presented actually on acetaminophen and the risk of ADHD and autism spectrum disorders. And I asked him if I could utilize his slides, and he was very kind to give me that permission. So I wanted to give him all the credit for this because his talk was really great. And so he talked about, look, we have in the last few decades realized that there's a huge increase in prevalence of ADHD and ASD, and some of it can be attributed to the fact that we're testing more, we're understanding more, we have better criteria for understanding this population, and that's great because we need methodologies to help our children. And the question then becomes, well, is it so much so that it doesn't explain just how we're screening for these patients? Is there something else that's contributing to this patient population? And so there's been a lot of studies. Europe kind of went through this wave a few years back, and they were doing a lot of studies on this. And I feel like this is just sort of gaining some traction in the US, whether or not this is an interesting topic or not. But the truth is acetaminophen use is really high in pregnancy, and that's because it has the greatest safety profile. NSAIDs, we don't like using, again, from the premature closure of ductus venosus and then the amniotic fluid. So we really need something to be able to treat patients. And media outlets have really picked this up, right? It's all over the news, and it's very frustrating to clinicians because, as you know, if it bleeds, it leads, right? Like if it's really bad and catastrophic, it's going to get somebody's attention. You're gonna buy into that newspaper more. It's just that it's frustrating that it doesn't show all sides of it. And in the end, we have to be able to take care of our patients appropriately. Now, with Surah Alwan, actually, Dr. Alwan's recommendation, she put in a group of people to talk about this and really make a response to some of the papers that were out there. And there's significant concerns that we had in terms of some of these papers coming out that had poor methodology. They had misclassification of the timing and the dose and the duration of the medication. And as you know, if you're in this field, that's always what we're talking about, right? To be really good at how we classifying things and how we do our studies. Well, it can be failure to account for confounding, right? What we didn't understand is why are those medications actually being utilized? We don't look at genetic factors or other environmental factors. And the fact that I think this is fascinating because 60% of women use acetaminophen, they use it for things like fever and migraines, which both have been associated with some of these adverse effects later on in children. And the fact that the use of medications, specifically some of these medications, also is associated with more pregnant people who actually have things like depression and anxiety, again, risk factors for some of these findings later on. So we certainly had some concerns about it, and this was through the wonderful, again, work from Dr. Alwan, who kind of put us all together and wrote this response. And I really loved the way she put some of this response to the literature that was coming out there. And this is a direct quote from that work. And while there is some acknowledgement to some of these limitations, there really isn't a discussion about consequences of this type of work being published. I think everything should be published, all the data. We have to be good at what we do. We have to find data now. And even if we're wrong 10, 20 years ago, doesn't mean we don't publish it and put science forward. So important. But we have to be mindful in how we discuss it. We have to be mindful that sometimes our findings are not the be and end all, and it makes a difference down the line when you're actually the person covering labor and delivery. Currently, we have this vaccine hesitancy problem, and we've seen it so much now through COVID, and that's because we have overinterpreted some of these flawed studies and found unfounded associations. All right, to turn a little bit to aspirin. So aspirin and metabolites salicylate not established to have an increased risk for birth defects. And so there's lots of studies out there. I kind of put some of the older ones here, the association between cardiac defects with certain exposures. But what we are concerned about with aspirin is really the high doses of aspirin. So high doses greater than 500 milligrams have an association in some studies with asthma, like we talked about before, and maternal bleeding. This is a big one, right? If somebody's on high doses of aspirin, their platelets aren't going to work. That's how aspirin actually works. And so if these platelets don't work, I'm concerned about taking somebody to the OR. And then is there, again, inadvertent closure of the ductus arteriosus that I don't want it to close too early. So now we do use a lot of aspirin now in pregnancy. If you know anything about the OB literature in the last few years, aspirin has actually been around in OB literature for decades. But in about 2016, I remember because I was pregnant with my second son, a study came out from the US and it was like, oh man, looks like low dose aspirin might actually be helpful for decreasing the risk of developing preeclampsia at the end of pregnancy. And so studies were looked at starting aspirin around 12, 13 weeks of pregnancy, giving it daily, low dose, 81 milligrams or 150 milligrams, and more on that in a second, and taking it for the rest of the pregnancy. And what it does is decreases the risk of preeclampsia by 24%, which is not a magical pill, but it's great in terms of community management, having less preeclampsia, having less deliveries, all that is helpful, and thereby decreases the risk of preterm delivery and growth restriction by about 14%. All really great things for obstetrics. Now, we use 81 milligrams in the United States. In Europe, they use 150 milligrams. And there's a little bit to be said about, it's just different dosing in different countries. What we have available is low dose. But there is some data to suggest that 150 milligrams might actually be a little bit better than the 81 milligrams. So some of us are changing our practice where we're doing a little bit higher dosing. But that being said, that is a low dose aspirin use, not above 500, 600 milligrams that could get us in trouble. Okay, so intrapartum pain management, I will change it over to my colleague.
Perfect. So we've kind of made it to labor and delivery using the usual characters for pain management before labor. So I want to just walk you through kind of the usual things that we do on the labor and delivery floor. And this pie chart, really simple here, but just breaking down in singleton pregnancies, what type of pain management are pregnant people using? And you can see that the vast majority of purple is represented by regional anesthesia or analgesia, which is going to be your epidural classically, or spinal or combined spinal epidural. We'll talk about that. And then you can see the remaining 30 to 40% are divided pretty equally among patients who exclusively use IV opioid therapy during labor and delivery for pain, and those who have no pain medication and just have that kind of natural birth, as they call it. I am going to go ahead and talk about something that's not on that pie chart just to get it out of the way, but nitrous oxide is something that's really interesting. When I first started training, we actually have nitrous oxide at our institution, and I thought, wow, what an amazing thing. But this is a self-administered inhaled gas. It's usually 50-50 mixed with oxygen. Sometimes it's used through a blender device, which is shown in the right-hand corner there, or it's pre-mixed in a canister, depending on the brand. But patients use this really to breathe through their contractions. and eliminate pain and anxiety. There's scavenging systems built in so that we're not getting a lot of environmental exposure. But here in the US, we really don't use it all that much. I think at the time that the biggest meta-analysis was published on this in 2014, there are only 5 centers in the United States that had this available. I'm hoping it's more now, but I couldn't find that statistic. But in places like the UK, 50 to 75% of pregnant women are using this during the course of their labor. And of course, with any exposure, you want to make sure, if we're going to use it, is it effective? And in this circumstance, there's definitely some advantages. It's a non-opioid alternative to pain management in labor. Patients can still be mobile while using this, so they can change positions very easily. And it doesn't affect labor progress like epidural may. And actually what's interesting is it's really reported to be associated with higher labor satisfaction. So we know that pain scores, it doesn't match up to epidural. But when you look at patients who exclusively use nitrous oxide, in fact, when 50% of users who only use nitrous oxide during their delivery process reported very, very high satisfaction, which was in comparison to those who had epidural, lower satisfaction. And those things all play into, what a patient experiences as the labor process. The disadvantages are there are some mild maternal side effects. And again, the pain control is not, as you can imagine, as good as regional techniques. And then from a fetal exposure standpoint, I think when you just think about the mechanism of nitrous oxide, it does rapidly cross the placenta. It is a gas, but it's also rapidly eliminated through breathing. So not only through maternal lungs, but once baby starts taking those first breaths, it's eliminated as well very quickly. We haven't had any evidence that shows that there's difference in APGAR scores compared to things like epidural or opioids, at least no worse APGAR scores. And then the only problem is despite such prevalent use in other countries, we really don't have great data on it. And most of it is because we limit the exposure time that we're actually looking at outcomes to basically birth until to discharge for that baby, and then there's really no long-term follow-up. There was one study I found where there was an association with childhood leukemia, kind of a modest association. The confidence interval included 1, but that was really the only thing that I found that had a little bit longer-term follow-up. There is some more data about occupational exposure. This is commonly used in, I think, dental offices and veterinary offices as anesthetic agents. So certainly there was concern for, pregnant people being exposed to this at their job. There initially in some of the earlier papers was an increased risk of miscarriage, but once you factor in and control for actually equipment that scavenges leak of that into the environment, and then of course, using that within the parameters that are now recommended by governing bodies, there's no increased reproductive risk associated with environmental exposure to nitrous oxide. The alternative, so about a third of patients are going exclusively parenteral opioids or IV opioid medications. And this comes from our practice bulletin at ACOG, where it basically just breaks down the most common IV opioid medications that we use and kind of ranks them by how long they last, lasting anywhere from 30 minutes to up to 4 to 6 hours. And these are really commonly used for patients, especially in the early phases of labor, to kind of delay the epidural placement, if that's what they choose to do with their labor management. And empirically, again, we do have some concerns about opioids that are administered only in that intrapartum period, that in general, whether if they're given through the IV, there's probably a higher risk of these things than if it's opioids used in the neuraxial component of analgesia. But lower APGAR scores, respiratory depression, lower muscle tone, poor feeding right at birth. And the fact of the matter is that there's no controlled studies about this. And there's also, because of that, there's really no guidance in terms of what's the last time during, cervical dilation or time before delivery where we really have to start worrying about these things. And certainly there you have to also factor in the components of uncontrolled maternal pain and that cortisol response and how that affects the labor process and the outcomes of that neonate immediately after birth. But these are things that our pediatricians are certainly thinking of. And the good news is time is treatment in this circumstance. So as long as you can provide respiratory support using usual measures, then this certainly gets better pretty quickly after that baby is born and able to clear those medications. Neuraxial analgesia, so what is the most popular in the United States, really falls into the category of epidural, most commonly in labor, where the catheter is left in place. You can see that in the picture on the right. And then spinal and combined spinal epidurals, which are typically used in more, I guess, unique situations. But compared to IV opioids, definitely better pain scores associated with this type of analgesia. And some of the earlier studies with the effect of on the neonate with this type of medication or pain control were a little bit more, I think, concerning. But now that we've actually really moved to this 2-agent system, we're using a lower dose of usually a local anesthetic like bupivacaine, and then also an opioid like fentanyl, probably are the most combinations. We found that that really reduces the maternal and neonatal side effects quite a bit. So I'm going to let you talk about that real quick.
So there's a couple interesting things that we do also in obstetrics at the time of delivery, or right before delivery, which is using local medication as OBs to help with pain management. So sometimes patients don't want to have an epidural, but they want a little bit of pain management more locally. We can do a bilateral paracervical block. So this is the view, a lot of women will know this because it's a speculum looking inside the vaginal vault. We see the cervix, and what you can do is where the vessels are supposed to be to avoid those, and you then inject a little bit of lidocaine. And so the lidocaine helps with that first stage of labor, right? Because the cervical dilation is the stuff that hurts a lot. It helps with that type of pain right there. So we have to be careful a little bit about the bleeding. So if you think about the cervix as a clock, you avoid the time frame of 3 p.m. and like a 9 p.m. because that's where the cervical branches of the uterine artery are located. And if you avoid that, you can safely place in this medication. And this is exactly what we're innovating here. So this is T10 to L1 with the paracervical block. It takes care of the cervix. Now another block is the pudendal block. This block is actually more for that second and third stage of labor, which is really when you are dilated about to have the baby, right? And so what we do there is with your guidance of your hand, you can use these special types of needles so that you don't hurt yourself, but you find the area of the ischial spine and you can insert a little bit of lidocaine, again, 1% without epinephrine. And that lidocaine is supposed to help during that time, really taking care of that perineum.
I'm going to kind of switch gears at this point in the talk. Certainly, I think you've appreciated that when you have in labor, we certainly use opioid medications quite often to help control pain. And for a lot of women, this is the first time that they are exposed to opioids throughout their pregnancy. However, there's certainly a growing number of pregnant people who are actually being exposed to opioids in the prenatal period. And that's what I really want to focus on right now. And in order to really talk about this subject, I just want to bring up 2 definitions. One is prenatal opioid exposure, which is really just you are pregnant and at any point in time during your pregnancy, you receive an opioid, whether that is a prescription or illicit use. And typically this is going to be patients with chronic pain who are on opioids perhaps before pregnancy, and that's expected to get worse with the physiologic changes of pregnancy. We're also really commonly are post-procedural pain management or post-surgical pain management for non-obstetric surgery that happens earlier on in pregnancy before delivery. The other side of that is opiate use disorder, which is really a chronic disease process where there is tolerance, craving, inability to control use, and continuing to use opioid medications or opioid substances, despite that person knowing that there are some adverse consequences. And I think when we really think about opioids in pregnancy, I think there's 2 ways to think about how that affects the neonate and how it affects the pregnancy. Number one is from a simple teratogenic standpoint. Are these actual substances, the actual chemical compounds, what effect does that have on the neonates or the embryo's development and the neonatal outcomes? But then I think there's also this kind of larger thing we have to think about, which is really the social implications and the long-term outcomes associated with that maternal infant dyad that are not necessarily related to the chemical exposure themselves, but the exposure of having this this type of, I guess, chronic disease process. So we'll go through both of those in kind of a circuitous fashion. But first, I just want to talk about kind of some 3 common opioids that are used during pregnancy and what effects we have in terms of birth defect data. So codeine is kind of the one of the older medications, really classically used in cough syrup as an anti-cough medication, or in pregnancy, we really see this as Tylenol number 3 in combination with acetaminophen for pain control, perhaps after a dental procedure. Codeine is actually metabolized in the body to morphine by liver enzymes. And when we look at the studies, there's actually quite a lot of studies looking at codeine exposure in early pregnancy. And when you look at this Norwegian study, which was very large, we don't see any survival difference, no increased risk of congenital anomaly. And then in some retrospective studies that were, smaller case series, really inconsistent data that's associated with some of the defects that are listed here. Now, hydrocodone, a similar, molecule that became really popularized between 2005 and 2011, most commonly prescribed probably in the combination form of with Tylenol as Vicodin. Again, with some animal data, there was a lot of studies that were negative, but in hamster data, there is at really extreme human doses, there's some central nervous system defects that ended up panning out. But really in human data, there was less available, but certainly some retrospective studies with first and second trimester exposure that really didn't show any increased risk of congenital anomalies. And oxycodone is kind of the one in the limelight now. I think empirically, when we discharge someone from a C-section, or whether really anyone has any surgery at the hospital nowadays, this is typically the opioid that they go home on, typically as a combination, again, with acetaminophen as Percocet. And less data here, just because this is sort of a newer drug that's being prescribed, but again, really nothing that is so compelling in some of the retrospective data that shows any risk for teratogenesis. But when you go to the CDC, you'll notice that there is certainly some advisories that they have for opioid pain medication in women who are planning to become pregnant or are pregnant. And the things that they cite are, number one, neonatal opioid withdrawal syndrome. And we will come back to that at the end. That's kind of where all these things intersect at the very end of the talk. But they do list neural tube defects, congenital heart defects, gastroschisis as birth defects, and then stillbirth and preterm delivery. So I thought, where does this really come from? Because when you really just do a cursory search of the studies, not a whole lot pans out. And one of the biggest studies where a lot of this comes from is actually this study that was published in 2011, which actually uses data from the National Birth Defects Prevention Study. Their group was from 1997 to 2005. And this was really collecting data on birth defects from multiple different pregnant people. And this was a retrospective self-report of these recent moms. So really to be included, you had to have exposure to at least one or more opioid used in a therapeutic nature. It could be any dose, any duration, any frequency. And that exposure had to occur at least 1 month prior to conception or within the first 3 months of pregnancy. The most common opioids that were reported were codeine and hydrocodone. Those were the vast majority. And then meperidine and oxycodone also made up some of those. But you can see this is kind of skewed toward more of the older, I guess I would say, opioid medications that were used for pain control. And of course, the outcome they were looking at was birth defects. So this table is by no means meant for you to actually read, but this is just showing the breakdown when you look at all of the different, both kind of a priori and then kind of what they looked at afterwards in terms of the birth defects they found in this cohort. The things that panned out were basically what the CDC reports. So some heart defects, along with spina bifida and gastroschisis. And you can see some of these associations are actually pretty substantial, being at least 2 times more than control. But I think the study also has several limitations. And I think the biggest thing that we have to think about here is the risk for recall bias. Again, all of these exposures were reported retrospectively by the moms, and most of the interviews where they talked about these exposures happened about 9 to 11 months after they gave birth. But some of these patients in this cohort actually gave birth, they were being interviewed about an exposure that happened because they were being interviewed 2 years after, and they were trying to recall things that happened in the first month of their pregnancy. So definitely some bias there. Of course, we talked about there's no dose, duration, frequency that you can really calculate a curve there in terms of what that exposure actually pans out to be. And then I think what also the authors said here is most of these were from surgical procedures, meaning whatever underlying illness perhaps that required the surgery that led to the opioid exposure, that certainly has some impact on potential birth defect causation. And then lastly, they controlled for some comorbidities, but not some common things like diabetes, which can certainly be associated with a lot of the cardiac defects. The other outcomes like preterm birth and stillbirth, have been studied multiple times. And I thought this was one of the best studies actually using Canadian healthcare system data, where they looked at multiple different exposures, again, for therapeutic use, but they really focused on confounders and tried to really eliminate that perspective from the data. So when you look at what they found, compared to any opioid exposure versus none, preterm birth and stillbirth were both modestly increased when they did their logistic regression. But again, I think even though this is so well controlled, I think there's still some confounders they may have missed, and I think some of this plausibly does also come into just what we were talking about with the kind of surgical exposures as well, being, there's certainly some other confounding principles that come into the underlying condition. Just a quick thing about opioids and breastfeeding, as we kind of get away from, the exposure, what happens if this exposure actually occurs for the first time postpartum, maybe a C-section patient who is, receiving oxycodone for pain control. Definitely difficulty suckling, some drowsiness because the baby's livers are not as efficient at elimination of those compounds, but a lot of times there's low transfer over into milk. Really, the things that we worry about is just telling moms to watch for central nervous system depression in their neonates when they're breastfeeding. The FDA does have a warning about codeine because that is metabolized to morphine. If that baby happens to be an ultra rapid metabolizer, that can accumulate very rapidly and have dangerous levels. Also, if moms are on really high doses of oxycodone or other opioids, that can sometimes be not recommended. And then again, just monitoring for those symptoms is probably all that's needed to have safe and effective breastfeeding if there is opioid exposure in the postpartum period. Now, I want to briefly just sidetrack into opiate use disorder, because certainly any prenatal opioid exposure certainly has the propensity to turn into a misuse. And this is particularly important in our pregnant population in the United States because it's actually an epidemic. And not to go through the statistics, but certainly opioid prescriptions are up in pregnancy, opioid use is up in pregnancy, and neonatal abstinence syndrome is also drastically changed in the past several years. And this is really relevant. Actually, this was published, I think, 1 or 2 months ago, but this is the most recent data in terms of maternal mortality, where we see mental health conditions actually are the most common cause for why patients die within the first year after giving birth. And the caveat here is that the majority of that category is actually made up from toxic exposures, overdose, and substance use disorder. So certainly a really big concern, because although that causes maternal mortality, the infant bonding and long-term infant outcomes are really affected by that. And this national data shows, where are these overdoses coming from? And you can see in the latter half of, in the last couple of years, really since about 2016, synthetic opioids, principally fentanyl, have really taken the limelight in terms of causative agents for these overdoses. And this has been reflected in the pregnant population. And this same chart really just showing data from the county in which we practice, where fentanyl really has taken over as the mainstay player here in opioid overdoses. So heroin, which was, 2016 really, was really, if we look at teratogenic data, there's really no association with birth defects, at least in terms of syndromes. Really, I think where a lot of the concern comes from are immediate neonatal outcomes like preterm delivery, growth restriction, perinatal death. And you can imagine that studies, distinct from what we've talked about so far, these studies are almost impossible to do. This is a very difficult patient population to engage in research. And there's just so much confounding with the mental health, comorbid mental health conditions and other substances that may be implicated in their use, that it makes really parsing out exactly what's causative here almost impossible. Fentanyl, on the other hand, which does have some therapeutic use, but has a really high propensity for misuse, animal data really hasn't shown any increased risk for birth defect syndrome either. But what I really do want to talk about is the ability for this to kind of perpetuate in pregnancy, and why is it so prevalent now, and why is it explaining so many overdoses? And it really is a combination of the cheap production costs, especially compared to heroin. It's a lot cheaper. I mean, it can be mixed with a lot of drugs that patients are getting off the streets, and high potency. So someone who, you basically have a situation where you have a dealer who doesn't know they're selling something that has fentanyl in it, a patient who takes that fentanyl or takes that drug not knowing there's fentanyl in it, thinking that it might be heroin, and in fact it is 50 times more potent. And that's where the overdoses come into play. So it was a very circuitous way to find an intersection of where prenatal opioid exposure and opiate use disorder come together into neonatal abstinence syndrome. And neonatal abstinence syndrome, NAS, really is an umbrella term for any substance exposure in utero that then has manifestations in the neonate. And neonatal opioid withdrawal syndrome, or NOWS, is particular to just opioid withdrawal, but really they share a lot of common features. Irritability, high-pitched cry, poor sleeping, poor feeding. These are the hallmarks. And we do know that the symptoms do not in any way correlate with the dose or exposure during prenatal period, whether it's licit or illicit, a lot, a little. There's really no correlation. What we do know is opioids in the neonate, this withdrawal syndrome tends to manifest within 2 to 4 days after delivery, and that's important. And there's certainly some other medications here, like SSRIs and nicotine, which are highly comorbidly used in these populations, in really any pregnancy, in fact, that can also kind of modify the effect and presentation of NOWS. And this table I think is really interesting because it really breaks down what the exposure is and when these peak symptoms come into play, and why this is really particularly important for NAS literature is because I think a lot of the NAS literature is older, and I think at that time there wasn't a huge understanding of the fact that things like nicotine, which tends to present withdrawal symptoms in the first 1 to 2 days, I think a lot of times in these studies was actually mistaken for opioid withdrawal syndrome. And that's certainly something in our NICUs we have to be very cognizant of, is a lot of times the opioid withdrawal is actually not what people think is going on. It's actually due to some other medication that actually causes withdrawal symptoms a lot earlier. And things like methadone and buprenorphine, you're going into day 3 and 4 of that admission. So these are just important things to keep in mind, more for our neonatal colleagues. Treating NOWS, non-pharmacologic and pharmacologic. I won't belabor this because this is certainly not anything I do, but we can give these babies that have really severe withdrawal symptoms. You can give them that some type of opioid to help with their symptoms and basically allow them to do the things they need to do, like eat, sleep, and be consoled. Or what things are really moving toward is what's actually called eat, sleep, and console, which is non-pharmacologic interventions that really rely on maternal-infant bonding and really just kind of those nurturing factors to calm baby down and allow that baby to eat, sleep, and console. And if it's doing the things that a baby should do, there's probably not a need for a pharmacologic intervention. And just really quickly, I want to show some data from our own hospital, where if you look in January of 2019, before we really rolled out this non-pharmacologic intervention, our baby stayed an average of almost 17 days in the NICU after birth. And now after rolling this out, as of last December, this is older data, but they are staying an average of 5.1 days. So that's a huge impact, not only on healthcare cost and utilization, but also in terms of how we really perceive, what is the danger and the effect of this neonatal exposure in utero. Similarly with how many days do these babies actually need to get treated with opioid medication, average of 10.9 days of treatment at the beginning of this time frame, and now we're almost treating no babies. Maybe 11% of babies that come through with NAS in our hospital are actually getting treated, and it's maybe 1 or 2 doses. The other things that we don't think about so much are torticollis and strabismus. These are seen a little bit more often in babies with neonatal or in utero opioid exposure. And not to belabor this, but these are 2 things that luckily, if they're identified early on, they can be corrected. And I think this is just one of those kind of not so teratogenic, but certainly an effect that can have long-term impacts in that child's life if they're not addressed and if they don't receive the care that they need early on after birth. So I hope I've demonstrated to you that, yes, certainly there are some concerns about prenatal opioid exposure. Maybe they're not so bad as we thought, but certainly something we have to keep in mind. But certainly if you look at the media, it's very inflammatory. And there's things about babies suffering and babies being hooked, and some of these are quite comical. But unfortunately, I think this problem has really been addressed more with stigma and kind of penalization in terms of really an objective healthcare outlook. And I think that's definitely affected some of our pregnancy outcomes. So what's really reported is you hear that, babies who are exposed to, whether it be heroin, fentanyl, oxycodone, they have developmental delay, behavioral concerns, ADHD, poor academic testing. But the research really, when you look at the studies, there's been nothing that supports that there's negative short-term outcomes on neurodevelopmental effects. So in the first 3 years of life, these babies look identical to their colleagues. And there's been really inconsistent data on long-term outcomes. And I think this really begs the question of, well, what's really the exposure we're being described? Is it really that one molecule that crossed the placenta and affected that baby's development? Or is it really the whole host of things that come with why that person was using opioids in the first place? And I think it really comes down to social determinants of health and healthcare equity, where probably these are just magnified because that situation for that baby is, this baby is experiencing a lot of these things socio-emotionally during birth, and that's probably where a lot of these neurodevelopmental outcomes really come from. And again, just to leave you with this last thought that, the consequences of discrimination are probably an opiate use disorder, at least this is my personal opinion, probably actually the way that healthcare personnel and the general population perceive this disorder is actually probably more dangerous than actually the exposure itself, just because of label avoidance. Patients are not getting the prenatal care they need. They are stigmatized in the hospital. We know that this leads to worse healthcare outcomes, delivery, and also treatment outcomes. And then this is what ultimately ends up probably being the detrimental effect for that infant and maternal dad. So sorry for the soapbox at the end, but that's certainly something that I think is an interesting kind of topic when you're talking about exposures. So with that, that's really the end of kind of what we had to say, and we'd certainly like to open it up for questions.
Wonderful. Thank you so much. That was definitely a very inclusive coverage of pain management in pregnancy and delivery and beyond, I guess. So thank you so much. I really appreciate it. So everyone, if you can unmute yourself, if you have a question, you can just pose it directly to the presenters. If you wish to just write it down in the chat box, then I'll be happy to communicate it to them.
Looks like there's a question.
Yeah, question.
Well, there's someone just raised their hand, I guess. Was it Wishan? Go ahead.
Hi, thank you for the talk. Sorry, I can't access my camera. I'm not sure how to work those electronic. Thank you for the talk. I'm Wishan. I'm an obstetric medicine physician in Canada, obviously. So I'm just curious. Often, when you prescribe medications for a postpartum mom on their way out the door, what are your instructions to them, and how long do you tell them to take their pain medications for? Is it forever, or until they run out, or until the pain stops? That's something that we as internists hate seeing on the other side, when their creatinine is through the roof and they are still taking opiates long after. It's like, why do you still need it? Oh, because my doctor told me to take it. I'm like, okay, just curious. Thank you.
No, it's a really great question. I actually had a lot of personal thought, and I'm going to answer it only because my partner is a lot younger than me. So it's true. I mean, well, a lot. But I did, I did start residency, 2006. And I distinctly remember, being an intern and your chief or your attending at time, okay, patient is leaving the hospital. They had a cesarean section. Of course, it's painful, but make sure you give them, Percocet. And I was like, how many tabs do I give? I don't know anything, right? The first time on labor and delivery, and like, oh, give 30 tabs. So it was like across the board, everybody gets the same number of tabs. That's a mistake, right? People don't need that kind of medication, and we're better at it now. And I certainly, now that we have this huge problem, we are better. And I know what my colleagues who are younger are being taught and what they're actively doing. But I remember thinking, I was like, well, I don't know, is it 30 for somebody who doesn't have any pain and 30 who has some pain? Definitely problematic. Now I want to say, I know what we do now. It's like, well, we ask them, you only take it if you need it. And we give them this much smaller amount of tablets if they've had a cesarean. Vaginal deliveries don't get really these tabs. Now, having been a person who had a vaginal delivery, I know the components of that were extremely painful, and I needed something to get me through the day or two. And so I'm cognizant that not everybody's is the same, and we have to treat people differently. But the short answer to your question is, when people ask, hey, do you tell them to continue the tabs? No, our answer is no. You take the tabs only of what you need. Excuse me.
And I think that brings up a good point too, that certainly there has been this shift that opioids are bad and we shouldn't be prescribing them. And there's definitely some truth to that. But I think as internists might appreciate too, high dose ibuprofen, we prescribe 800 milligrams 3 times a day for some people. Taking that is also not without risks as well. And I think we probably do a better job of describing the risk of opioids, but not so much the risk of NSAIDs in every patient population. And we certainly don't, I think, do a great job of making sure that there's no peptic ulcer disease or some contraindications. I'm sure there's some people that leave the hospital that maybe a high dose NSAID isn't the best thing for them in efforts to try and reduce our narcotic prescribing.
Excellent. I have another question from Lori. Any thoughts about nitrous oxide use earlier in pregnancy, such as for dental procedures?
So I think that's a great question. I didn't come across any, I guess I didn't come across anything specific that looked at, pregnant patients who were exposed during a procedural setting. I think overall, if that was what the dentist recommended, I think for that short period of time, it would be okay. When you look at some of the studies that looked at exposures that really showed adverse effects, they were using more than 50% concentrations of nitrous oxide, and it was almost for over 24 hours of exposure. So these were really kind of exaggerated, I think, exposures that ultimately conferred some of that risk. But I think as long as you had a conversation with your patient and you presume that a dental procedure is fairly short, I think that would be perhaps a really useful tool and probably safe for the pregnancy, especially because of that rapid elimination after administration.
Mm-hmm.
We really worry about dental disease and pregnancy. I think what I hate the most, I think, is when I get as an obstetrician, oh, well, I'm not going to extract this tooth, or I'm not going to do this, whatever, minor dental procedure because they're pregnant. It's like, if she gets an abscess, we're going to have a big problem. We're going to have risk of preterm delivery. In fact, we have somebody on our currently in the hospital mid gestation because people would not take care of her. She has a terrible abscess for which she had to have a surgical procedure. In other words, like ENT was there. She went under general anesthesia. This had to be open. She has an active drain in there because people wouldn't take care of her. And I think that's really, really, really terrible. So when people do local anesthetics, it doesn't bother me. I want dental care to be almost on the forefront of taking care of somebody during obstetrics.
Absolutely. Right. Any more questions from anyone else? I had a question while we wait for if there's any more questions. This was probably not part of what your expertise, but the use of non-pharmacological pain management in general has been pretty popular, specifically for pregnant women who think that it's probably less risky than pharmacological treatment. But that can include things like complementary medicine, like acupuncture or acupressure, massage, or physical therapy, or some kind of aqua therapy. So do you have any comments on that? Any risk on the use of non-pharmacological pain management in pregnancy?
I can answer a little bit about this. So I think the older I get, the more complimentary maybe I get, meaning that I like the idea of doing things like cognitive behavioral therapy. I like the idea of even prenatal massage and mindfulness and meditation. Something that as somebody who's grown up in Western society, I really didn't have enough appreciation for it, and I think it's part of that tender loving care of a pregnant person, and I think it makes a difference. If you're a good clinician, if you talk to them, if you listen to them, if you give a way for them to access you, to ask questions, if you give them something that empowers a patient to take care of themselves, I think if you call it a placebo or the activity of that helps. Now, I think what you're also referring to are herbal medications, and that we certainly have to be careful about. We talk about that a lot within OTIS and Entis, right? Those things are not FDA approved. We have no idea what the concentration is in some of those things that are being sold. And that's where I may be worried. So I I am so much more apt to give somebody an SSRI to treating depression than I want them on Black co-host, right? Like, at least I know I'm giving them. I can get a psychiatrist who has perinatal experience, and we can work together. But the other things that are maybe not medication type wise, I do think they have a role in medicine. I do think they have a role in pregnancy as well.
Mm-hmm. True. Yeah. Excellent. Do we have any more questions to the speakers? I don't see anything in the chat. Well, I guess that ends our, excellent presentation. Thank you with all this. Yes. So Lori was asking if all the slides will be available afterwards. Well, this session is being recorded, so you can have a copy of I guess we can post it somewhere, so you'll be able to have
we're big
access.
proponents about. I think you're okay with that.
Yeah.
We're trying to do this with OTIS, where we can post slides up. So feel free to share these slides within the members only part of OTIS.
Yes.
We really want people to use it. Every time you use it, I really don't care about my slides so much, but if you're using Tony's, like, make sure you give credit where credit is due, but feel free to use it and read it and study it, whatever is helpful to our members.
Wonderful. Wonderful. Thank you so much. We really appreciate it. And thank you so much for being here today, everyone. Thanks for being here, and thanks for your presentations.
Thanks so much.
Thank you.
Thank you.
Bye-bye.
Bye.